Hello, my name is Bella Harrison, and today I will be presenting an academic discussion of a complex intrapartum case using the SNAP framework. This case concerns Ruby, a 36-year-old multiparous woman at 38 weeks and 2 days of gestation. She presents with a rupture of membranes and a fetus in the right sacral anterior breech position. Before applying the SNAP framework, I want to briefly emphasise on why this case is particularly significant. Breech presentations at term occurs in around 3 to 4% of all pregnancies. And although most women are offered a caesarean section, a proportion of women, particularly those who have delivered babies before, may be candidates for vaginal breech births under the right conditions. However, breech presentations are still associated with higher rates of perinatal morbidity and mortality, making this a topic of ongoing debate and clinical importance. So frameworks such as SNAP allow us to structure clinical reasoning in a clear and systematic way. They help to ensure that the case is considerably holistic and that the main problems are prioritised and the final management plan is evidence-based, safe, and justifiable within professional standards. So in this presentation today, I will begin by summarising Ruby's case. I will then narrow it down to the main clinical issues, analysing these issues in greater depth. I will be using current guidelines and evidence, and finally I will present an appropriate management plan. So now we will move on to the S in the SNAP framework, which is addressing and summarising the case. So we know that Ruby is a gravid of 5, para 4. Her obstetric history includes 4 previous spontaneous vaginal births, all of which were uncomplicated and occurred between 38 and 40 weeks of gestation. So her pregnancies have been described as overall uncomplicated. However, there are key limitations. She has had minimal antenatal attendance, with her last appointment being at 28 weeks. So from this, it means that she has missed vital opportunities for third semester screening, such as growth scans, GTT for gestational diabetes, the Edinburgh Postnatal Depression Scale, family and domestic violence screening, and a review for potential hypertensive disorders. We also lack information on fetal growth patterns, the placental position, and the presence of any other obstetric abnormalities. So from this, these gaps adds uncertainty to her risk profile in labour. At 38 weeks and 2 days, Ruby presents with a suspected rupture of membrane, mild irregular contractions. On admission, her maternal observations were within normal limits. She was afebrile, her blood pressure was stable, and her blood results were all normal. Her fundal height measured 37 centimetres, which is appropriate for her gestation. She has no significant medical history, and on abdominal palpation, we do find baby in a longitudinal lie. A hard, round mass was then palpated at the top of her fundus, and the fetal heart was auscultated in the upper right quadrant. This raises suspicion of a breech presentation. The breech was described as free and ballotable, not engaged in the pelvis, and Ruby also reports that her baby has been very active with strong and frequent movements. A speculum examination confirmed that Ruby has a rupture of membranes with meconium-stained liquor. The CTG was commenced and was reactive with baseline variables and accelerations present. Contractions were occurring 2 to 3 in 10 minutes, and a bedside ultrasound then confirmed her baby to be in a right sacral anterior breech position. So in summary, Ruby is a multip woman in early labour at term, presenting with rupture of membranes, meconium-stained liquor, and a ballotable breech in the right sacral anterior position. Now that I have summarised the the presentation, I will move on to the N in the SNAP framework, which is to narrow down the differentials and identify the main clinical issues. So from Ruby's presentation, 5 central issues emerge to me. First of all, we have got a right sacral anterior breech position. Now, this is a complex presentation. This requires specific intrapartum expertise. Secondly, we have got a rupture of membranes with meconium. This, in combination, increases the risks of fetal compromise and an umbilical cord prolapse. Thirdly, we have a ballotable breech. Because the presenting part is not engaged in the pelvis, vaginal breech births become less safe. Fourth limitation is the lack of antenatal care and the absence since 28 weeks of gestation. This does cause the uncertainty about the fetal well-being and the potential undiagnosed maternal conditions. And finally, the decision around the mode of birth. The key management question is whether Ruby could attempt and safely deliver the baby vaginally, or whether a caesarean section should be recommended. Having narrowed down these key 5 issues, I will now move on to the A part in the SNAP framework, which is to analyse them in detail with reference to the best available evidence. So firstly, as discussed previously, we're going to talk about the right sacral anterior breech presentation, which to say is more favourable than a posterior breech because it promotes flexion and descent in the baby's head. So both RANZCOG guidelines 2017 and the NICE guidelines 2021 acknowledge that vaginal breech births may be reasonable in multiparous women under careful, controlled conditions. However, there are systematic reviews and large cohort studies that show perinatal morbidity and mortality remains higher in breech births compared to, say, a cephalic presentation at birth. So, for example, the term breech trial by Hannah et al. In 2000 demonstrated higher neonatal morbidity and mortality with planned vaginal breech births compared to planned caesarean sections. Although subsequent studies have highlighted there is limitations in this trial design and emphasises the role of having skilled attendants in these guidelines. So in short, a vaginal breech birth can be considered in selected women, but requires strict criteria such as senior support and continuous monitoring. So moving on, secondly, we've got the rupture of membranes with meconium. Meconium is not unusual in a breech presentation and does not always indicate compromise from the fetus. However, when combined with a rupture of membranes and a ballotable breech, it becomes concerning, as the risk of cord prolapse in a breech presentation is significantly higher than a cephalic. The Royal College of Obstetrician and Gynecologists estimate an incidence of cord prolapse to be 1 to 2% in all breech births, which is compared to less than 0.5% in cephalic births. Cord prolapse is a timely, critical obstetric emergency. It is associated with higher rates of perinatal mortality unless delivery is happened rapidly. So this case would end up in a caesarean section emergency if there was a cord prolapse. So therefore, a rupture of membranes with a high mobile breech presentation presents major risk factor, which will influence Ruby's mode of birth. Thirdly, as discussed, is a ballotable breech. A breech that is ballotable is not engaged. It is considered unsafe for a vaginal birth, and the NICE guidelines specifically state that a vaginal breech birth should only be attempted if the breech is engaged in the pelvis during the labour. And in Ruby's case, as discussed, the breech remains free and mobile, which is a significantly increase of risk for cord prolapse, failure to descent, and an obstructed labour. Fourthly, Fourthly, we have limited antenatal care. Ruby has not been reviewed since 28 weeks. This absence of care raises several clinical uncertainties. One being fetal growth restrictions, which may have gone undetected, gestational diabetes screening, which may not have been tested for, and hypertensive disorders that may have not been identified. The Australian Pregnancy Care Guidelines highlights that inadequate antenatal care is associated with poorer outcomes, including stillbirth, fetal growth restrictions, and an increased perinatal mortality and morbidity. The gap in Ruby's care adds an extra layer of risk and makes proceeding with a planned vaginal birth less advisable from the healthcare team. Finally, the decision on the mode of birth. On one hand, Ruby is a multi woman, which would genuinely increase her chances of a vaginal breech birth success. But on the other hand, the combination of a high bloodable breech, rupture of membranes with meconium stained liquor makes a vaginal breech quite unsafe. Both the NICE and RANS-COG guidelines recommend caesarean sections when the breech is mobile at the onset of labour. Therefore, the safest and most evidence-based mode of care for Ruby is a caesarean section. In summary of the analysis, although Ruby's history of having multiple children vaginally might have supported a vaginal birth under different circumstances, her current presentation makes a caesarean section the most appropriate clinical recommendation. I will now move on to the final stage of the SNAP framework, which is to present the management plan. So the P, present the management plan, which is the management plan must address both immediate and intrapartum priorities and the decision on the mode of birth for Ruby. Immediate priorities would include establishing intravenous access. This allows the team to administrate fluids or medications and provide quick access should emergency delivery be required for her. Commencing a CTG, which is continuous electronic fetal monitoring, which will detect for any early signs of fetal compromise. As the team, we will minimise vaginal examinations to reduce infection risks and to avoid dislodging the mobile breech. We will be alerting both the obstetric and anaesthetic teams so that senior clinicians are available immediately when we do need them, if we need them. Regarding the mode of birth, so as discussed, there are two options. Firstly, as we've said, a vaginal breech birth, which could only be considered if the breech was engaged, labour was progressing normally, and the fetal head was not hyperextended. And we must have skilled clinicians present to consider this. And in Ruby's case, these criteria are not met. So unfortunately, therefore, the option which is the safest and the most appropriate is a caesarean section, as a caesarean section will minimise the risk of cord prolapse, obstructed labour, and any intrapartum complications that may arise from her current situation. A caesarean section will provide control on the environment, which both the maternal and fetal safety can be prioritised. It is important to acknowledge the principles of woman-centred care, specifically in this case. In practice, I would involve Ruby ensuring that she is fully informed about her condition, the risks of each option, and the reasoning behind the recommendations for a caesarean section. I would also meet her preferences when possible, such as involving her partner, maintaining a calm birth environment, and facilitating skin-to-skin contact and delayed cord clamping once baby is out, if safe. This approach aligns with the NMBA professional standards, which emphasises both evidence-based practice and respect for women's values and choices, which is so important. So in conclusion, Ruby presents with a complex intrapartum scenario, a RSA breech, rupture of membranes with meconium, a bloodable breech presenting part, and limited antenatal care. By applying the SNAP framework, I have summarised the case, narrowed down the key issues, analysed them in depth using evidence and guidelines, and presented a management plan that prioritises safety and woman-centred care. Whilst a vaginal breech birth can be appropriate in carefully selected women, Ruby's specific presentation makes a caesarean the safest and most evidence-based recommendation. This case highlights the value of systematic frameworks such as SNAP, which I've used today, and the importance of integrating clinical reasoning, guideline-based evidence, and woman-centred principles into intrapartum care. So thank you for listening, and I hope you enjoyed my presentation and my SNAP framework on Ruby's case of a breech presentation.